I shared, we have a wonderful day lined up with amazing expert speakers, and I appreciate that you are all here today, despite what could have been a bad weather day. You just never know, right? So now I'm going to introduce Dr. Yong. Advances in MS Lifestyle Medications and Brain Repair is the title of Dr. Yong's presentation. He will discuss the many research advances occurring in multiple sclerosis, which include the role of lifestyle factors such as diets that alter immune cells and exercises that promote the repair of myelin in experimental models. Dr. Yong will provide an overview of advances in MS treatment, including medications aimed at promoting brain repair. He is a professor and co-leader of the MS NeuroTeam at the University of Calgary, and he directs the provincial organization Alberta MS Network. Dr. Yong has published 290 peer-reviewed manuscripts, mostly on MS, and his research has been translated into phase 3 clinical trials in MS and spinal cord injury. Dr. Yong is a past chair of the Medical Advisory Committee of the MS Society of Canada, and this and other volunteer activities have resulted in Dr. Yong receiving the Queen's Golden Jubilee Year Medallion. Dr. Yong is on the editorial board of 7 international journals, and he is the honorary editor-in-chief of Neuroimmunology and Neuroinflammation. So we thank Dr. Yong for being here, for coming all the way from Alberta. Appreciate that, and please join us at the podium.
Thank you, Angela. Good morning. Can you hear me well in the room? Okay, all right. We'll do our best. So, all right. Thank you. Better? Well, first of all, I want to thank Angela for this kind invitation. And second, to thank you for making a way out this morning. I know the weather is not the best, so thank you for your resilience, your fortitude, and hopefully this will be a very educational day for you. So as Angela said, this morning I'm going to be talking to you about many of the advances that are occurring in MS research and treatment. I want to impress upon you that there's a lot of research ongoing here in Canada and around the world on MS. The advances have been multiple, they have been amazing, they have been very exciting. I know they're not fast enough, but nonetheless, I want to share with you that a lot of things are happening in the world of MS research and treatment. So if I leave you feeling very hopeful at the end, that is indeed my goal. So I want to, for today, focus on areas around lifestyle, how that might affect MS well-being. I want to tell you a little bit about the medications that we now have, including medications to try to foster brain repair of lesions in multiple sclerosis. So that's the goal this morning then. I will begin by first reintroducing you to MS, including the pathology of MS, explain to you why MS occurs in the first place. So I'm going to use this board here so that I can use this pointer to point at the slides. I'll begin with this slide just to tell you about some of the players in multiple sclerosis. So let me orient you first to this schematic. I'm showing you here the bloodstream, and over on this side, the brain and the spinal cord. So normally there is a blood-brain barrier that keeps immune cells that are circulating in the bloodstream from entering into the brain and spinal cord. So normally then we have a variety of immune cell types that circulate in blood. They are very important to help us fight infections. In multiple sclerosis, some of the immune cell types become overly activated. They then gain the ability to cross this blood-brain barrier that normally excludes them. These immune cells then enter into the brain and spinal cord to disrupt the brain and spinal cord. Within the brain and spinal cord, we have a lot of nerve cells referred to as neurons, and here I'm showing you two neurons or two nerve cells. Here is neuron 1, here is neuron 2. You see this nerve cell with its long stalk that is called an axon, or the nerve fiber. Some of these nerve fibers can be very long. In the spinal cord, for instance, some of these nerve fibers are over a meter in length. And therefore, for a message to pass from the body of this neuron down to its end, we need mechanisms to speed up that conduction of message. And that mechanism is enabled by this wrapping, also referred to as myelin. This myelin wrapping is like an insulator, if you like. It speeds up the conduction of nerve impulses. That myelin is formed by this cell type that is called an oligodendrocyte. So in the normal situation then, this then allows this nerve cell to talk to this nerve cell. Messages are transmitted from one to the other and transmitted very, very rapidly because of the myelin insulator or wrapping around nerve fibers. So with that speed of transmission of messages, this nerve cell talks to this, talks to other nerve cells, and then with the rest of the body. In multiple sclerosis, when these immune cells enter the brain and spinal cord to then begin to destroy some of these nerve cells and connections within the brain and spinal cord, that becomes multiple sclerosis. That disrupts the transmission of impulses, and depending on where these injuries occur in the brain and spinal cord, that will dictate the symptoms that result. So that if these lesions are occurring in the optic nerve, for instance, one would have impairment of vision and the like. So these then are some of the players in multiple sclerosis. We move on to this example here, where we can actually visualize these events occurring in the brain of multiple sclerosis. This happens to be a donation from an individual that died with multiple sclerosis, came to the brain bank, and from these samples, we are able to take sections and interrogate these sections in great detail. So this shows you this blood vessel here, and in green, the immune cells, and in this background is the brain. And it shows that in multiple sclerosis, many of these immune cells have now entered into the brain in large numbers. And what happens when they do enter into the brain and spinal cord in large numbers? Here I'm depicting for you an experiment in tissue culture. You are seeing here in green a nerve fiber, and I'm not sure if you can see immune cells in the background. They're supposed to be blue. And this is a video that I'm going to ask our colleagues behind to turn on for me, please. Okay, so hopefully you see these immune cells in blue engaging, just like Pac-Mans, if you like, and then eventually transecting that nerve fiber. If you go back and repeat that one more time, that would be great. So again, immune cells attaching and then eventually transecting this nerve fiber. So these are some of the things that occur in multiple sclerosis. And with that, I'm showing you this schematic, first depicting the normal situation of one nerve cell and another nerve cell here, this oligodendrocyte that extends multiple processes. These processes contact these nerve fibers and wrap and become the myelin insulator. So here's the normal situation of an oligodendrocyte with the myelin around the nerve fiber of this nerve cell. In multiple sclerosis, we end up with loss of this oligodendrocyte because the immune cells have attacked and destroyed that oligodendrocyte, and as a result of that, the loss of the myelin wrapping, and with that, the disruption of transmission of nerve impulses. Over time, one also loses the nerve cells as well. So that aggravates the situation in multiple sclerosis. So basically then, this is the neuropathology of multiple sclerosis. It involves the overactivation of certain types of immune cells. Not all the immune cells that we have are overactivated in multiple sclerosis. Some of the bad ones become overactivated. They gain the ability then to cross the blood-brain barrier. They enter the brain and spinal cord to then produce injury. And the injury includes the loss of the myelin wrapping and the loss of the nerve fibers or axons. And because these axons are crucial for transmission of messages, the conduction of these nerve signals from affected brain or spinal cord areas to other areas of the body become affected. And as I've indicated, if such lesions occur in the optic nerve, that leads to disruption of visual acuity. If it occurs in another part of the brain that controls movement, this then results in impairment and difficulty in movement. So again, an overview then of multiple sclerosis, here in a schematic that we've drawn, again depicting the bloodstream where these immune cells circulate, the blood-brain barrier that normally would keep these immune cells out of the brain and spinal cord, showing here a nerve cell or a neuron with its nerve fiber. And normally, one or two of these immune cells may go in to patrol to make sure that there's no infection within the brain and spinal cord. This is the normal situation and everything is healthy. In multiple sclerosis, certain types of immune cells become overactivated. They multiply. Many of these immune cells that are so-called bad immune cells, if you like, increase in numbers. They also increase in activity. They gain the ability to cross the blood-brain barrier. They enter into the brain and spinal cord to now begin to produce the injury that you saw in that video earlier on. And over time then, we lose this nerve fiber. So I'm going to come back to this schematic a number of times in order to show you multiple sclerosis, and then also what happens when we use certain types of treatments, okay? But essentially, this is an overview of multiple sclerosis. Just for your information, we have 2 hours this morning. In the first hour, I'll go through some of these slides, and then in the second hour, there will be lots of time for questions, particularly if you have questions around the research that is occurring in multiple sclerosis. I'm hoping that I'll be able to address your questions. So what causes all of these in the first place? Why do certain types of immune cells become exaggerated in numbers as well as activity? So what is the initial trigger? So at this point, we still don't really know what the initial triggers of multiple sclerosis are, and we think that there could be multiple. But whatever the initial trigger, what we end up with is the overactivation of the bad immune cells in multiple sclerosis. So we don't really know the initial trigger. We do know of some of the factors that help with the development of multiple sclerosis. We know that genetics is one, so that in the normal population, in the general population, in the Caucasian population, the risk of multiple sclerosis is 1 in 1,000, so that of 1,000 individuals, 1 might get multiple sclerosis in the general Caucasian population. But if you have 1 family member affected with multiple sclerosis, the risk goes up by about 10 times. In identical twins, if one has MS, the risk of the other developing MS is about 30%. So that there's genetic predisposition in multiple sclerosis, that is one risk. But because even in identical twins, when one gets MS, the risk of the other getting MS is not 100%, that tells us that genetics cannot account for all multiple sclerosis. So that brings in the role of environmental factors. that some environmental factors out there in the environment also help to overactivate immune cells in multiple sclerosis. So we know that in multiple sclerosis, there likely is this mix of genetic and environmental factors, some of which I'm just going to highlight shortly. So following that, whatever the initial trigger is, and like I have indicated, that may be different from one individual to the next. The end result, though, is the overactivation of immune cells that go uncontrolled, that then enter into the brain and spinal cord to produce injury. And that ends up with multiple sclerosis. So one of the advances in MS is this recognition that there are modifiers of all of these immune aberrations, if you like. So here I'm depicting for you an immune cell that has become excessively activated, now gaining the ability to enter the brain and spinal cord to produce injury. So some of the environmental factors that have some popularity in the scientific literature include some pollutants that are out there that can help immune cells acquire a very pro-inflammatory, overactive phenotype. So there's some pollutants out there that have been implicated. Viruses, infections with Epstein-Barr virus, for instance, is thought to also help facilitate the activation of immune cells that help contribute to MS. So these are some of the environmental factors. And then there's some lifestyle factors as well that we recognize to also help drive the aberrant immune processes, smoking being one of them. There is a higher risk of acquiring MS amongst smokers than non-smokers. And for those with multiple sclerosis, the risk of progression of multiple sclerosis goes up when one is a smoker compared to non-smokers. And some of the biology behind that includes smoking increasing the activity of immune cells so that these immune cells gain the ability to cross the blood-brain barrier. So smoking is now recognized to be a bad lifestyle factor for multiple sclerosis. There's also an increasing literature around high salt consumption. So when you eat your lunch afterwards, don't sprinkle too much salt. And the biology behind that is that salt drives the formation of a very pro-inflammatory immune cell type so that they become exaggerated in numbers as well as activity, and again, gaining the ability to enter the brain and spinal cord. So there's an increasing appreciation that high salt consumption, smoking are bad prognosticators for multiple sclerosis. And against that background, I've already referred to genetics. There are about 200 genes that are now implicated in increasing the risk of multiple sclerosis. Many of these genes don't have very strong driving force, if you like, but when they come together in some mixture, this now results in immune cells being more easily activated, more easily becoming the bad type, if you like, following exposure to whatever that is out there. So genetics do have a role in helping to drive the disease process. These are all the bad things, if you like. And then these days we also recognize that there are some environmental factors out there that are protective. Vitamin D being one of them. There is the geographical distribution of multiple sclerosis that some of you may be aware of, and that is less multiple sclerosis in the equator compared in the temperate areas. In the equator, there is a lot of sunlight, and particularly ultraviolet B that we get from sunlight. Ultraviolet B is very important in generating vitamin D in us. And it turns out that vitamin D is actually an immune suppressant, if you like. It prevents the excessive activation of these immune cells. So there's a lot of literature now around the benefits of adequate vitamin D supplementation in multiple sclerosis. And the biology behind that seems to be that vitamin D prevents the excessive activation of the bad immune cell types. The importance of the sun is highlighted by, a tinge of a sunburn giving us about 10,000 units of vitamin D. This compares to a food source that is rich in vitamin D, like salmon steak, that gives us only about 1,000 units of vitamin D. So that tells you about the power of the sun in generating vitamin D in us. And I emphasize the ultraviolet B of sunlight, because in big sky places like Alberta, where we get a lot of sunlight, well, actually for 9 months of the year, the ultraviolet B, because of the angle of the sun, is actually not reaching us. So we have sunlight, but we're not getting the ultraviolet B radiation. And that's why in Canada, many of the MS clinics would advocate vitamin D supplementation. Our clinic in Calgary advocates 4,000 units per day of vitamin D3. There is a literature indicating that it's actually very difficult to overdose yourself with vitamin D. The live gut that is out there exposed to sunlight in the equator all the time and becomes black, that person doesn't die of vitamin D overdose. So, our clinic advocates adequate supplementation, at least 4,000 units of vitamin D3 a day. And again, the biology behind that is that vitamin D is actually quite effective in modulating the activity of immune cells and in preventing the formation of those overactive bad immune cells, if you like, that we find in multiple sclerosis. Against this background as well, there is the increasing appreciation that the microbiome also affects well-being in multiple sclerosis. And you will hear about the microbiome, particularly the gut microbiome, from one of the speakers today, Jan Walters. I don't see him in the room at this. Oh, hello. So Jan is going to tell you, he's a world expert on the gut microbiome in multiple sclerosis. You will get some fascinating insights into the gut microbiome. So the microbiome, just briefly, is this population of microbes that is on us, on our skin, in many tissues, and in particularly the gut. You might have heard of the gut flora, the gut microbiome. In multiple sclerosis, there's this increasing appreciation now that influences health. And I just want to show you one data slide in that regard. I'm not sure if Jan is going to show this. He's going to show this later on. But let me walk you through this particular experiment that comes out from a group that is based in Germany. It was published last year in a journal called PNAS. And what they did was they, and I'm not reading this slide very well here. So the experiment involves using identical twins. One has MS, the other does not have MS. They took poop, if you like, from these individuals, and from the feces isolated a fraction that contains the gut microbiome. They then injected those feces material into mice, and a particular strain of mouse that will develop spontaneous MS-like disease. So in mice, we can produce MS-like disease by actually causing the immune cells to become overactive. So this is a special strain of mouse in which these mice will, in later life, go on to develop MS-like disease. So what the investigators reported is that in these mice that are given gut microbiome from the twin that has MS, subsequently, these mice that were exposed to that feces are more liable to develop multiple sclerosis compared to mice that were given feces from the non-MS subject. This is actually quite instructive because it tells us that although genetics has a role in multiple sclerosis, genetics cannot explain everything. There are other factors besides genes, one of which appears to be the gut microbiome. These are identical twins. One has MS, one does not. The feces from the MS twin can produce this immune abnormality and MS disease in mice compared to the feces from the non-affected twin. Yeah, so this speaks, and you'll hear more about this from Jan Walters. But all of this brings us to the appreciation that in multiple sclerosis, we deal with ultimately the activation of immune cells, and that upstream, there are a number of factors that go on to contribute to that abnormality, and they include not only genetics, but also the gut microbiome, lifestyle factors such as smoking and salt consumption, and also some environmental factors that trigger the activation of these immune cells in the first place. And this is occurring in the context of insufficiency of protective factors such as vitamin D. Okay? So a number of things coming together then to affect multiple sclerosis. While I'm talking about the gut microbiome, I just want to highlight that there's also an increasing appreciation that certain types of foods seem to be able to promote the formation of these pro-inflammatory, overactive immune cells in multiple sclerosis. Some of these include red meats, milk-derived fats, saturated fats. These tend to produce pro-inflammatory environment in patients with multiple sclerosis, whereas foods that seem to be protective by generating yet another type of immune cells, the so-called anti-inflammatory, the protective immune cells. These include fish and also a variety of vegetables. The literature around diet and multiple sclerosis is actually not very immense and not very well tested. So it's actually very, very, very difficult to have guidelines on what foods one should have. But here's some literature with regards to certain types of foods and whether or not they produce pro-inflammatory or anti-inflammatory cell types. And I generally tell people that if you feel good with some types of diet, well, stick to that, right? It probably affects your immune cells and your gut microbiome in a favorable way. So while the literature is not very immense around foods, and while the MS societies, for instance, cannot give you strong guidelines on what type of foods to avoid, here are some types that changes the immune cells to some extent. Yet another advance that I want to point out to you is in the area of medications. We have many medications for multiple sclerosis these days. MS, as we have already defined, is an immune-mediated disorder. We don't really know what sets it off, but we know that as consequent to that, immune cells are abnormally activated, and so forth. And therefore, the therapies that we have been directed towards this overactive immune system. These therapies are also referred to as immune modulators, modulating the immune system, or disease-modifying therapies. And we have a whole slew of them now. So this shows us, this is a publication in 2018. It shows the medications that are now used in multiple sclerosis, the disease-modifying therapies to reduce the occurrence of multiple sclerosis attacks. The first drug was introduced in 1995. It's one of the interferon betas. It's called betaseron. And then you have two other interferon betas coming into being here, Copaxone or glatram acetate coming in here. So a fairly slow pace, if you like, early on. But then look, in the last few years, quite a number of medications now being approved for use in multiple sclerosis. So in MS now, we have some 15 medications that are approved by the FDA for use in the relapsing remitting form of multiple sclerosis. And I'm not seeing it very well from here, but one of these drugs is now also used in primary progressive MS, ocrelizumab. And I'll mention progressive MS shortly. So we have a whole slew of medications now. It is said that MS is the second disorder after HIV infection with the most number of medications that have come through in a given short period of time. This is just amazing. MS leads all neurological conditions in terms of the medications that have come down the pipeline and the medications that will come through the pipeline in the next few years. So how do our medications work? So the next few slides, I'm just going to give you a sense of how our medications affect the immune system. I'll begin with this that you have already seen. I've told you about the normal situation of immune cells being kept out of the brain and spinal cord and where the nerve cell is healthy. I've told you about the excessive activation of immune cells in multiple sclerosis and how they gain the ability to enter the brain and spinal cord to disrupt the elements within. So with regards to the interferon betas, our first crop of MS medications that were available, they reduce the activation of these bad immune cells so that we don't have too many of them. They also block the capacity of these cells to cross the blood-brain barrier. And as a result, we have fewer of these bad immune cells now within the brain and spinal cord to produce injury. So these are the principal mechanisms of the interferon betas, Copaxone, Avonex, Rebif, and the like, by reducing the generation of these bad cells, preventing their entry, and therefore excluding these invaders and these bad players from the brain and spinal cord. The next medication that I wish to talk about is glatram acetate or Copaxone, given by injection. And again, beginning with this scenario in multiple sclerosis, Copaxone or glatram acetate works actually by changing the nature of the bad immune cells. So now I've put a smile on their faces. So these are more favorable anti-inflammatory type of immune cells. These cells can actually enter into the brain to produce well-being within the brain and spinal cord. So this is glatram acetate changing the nature of the immune cells. We also have medications such as Tysabri, given once a month by injection, that blocks the entry of these immune cells into the brain and spinal cord by acting at the level of the blood-brain barrier to keep these intruders out. And as a result, we have fewer of these immune cells in the brain and spinal cord. A last example here is a new crop of medications that work by killing these bad immune cells. An example is this medication alemtuzumab, also called Lemtrada. And what it does is it depletes immune cells, and as a result, very few of these can make their way into the brain and spinal cord to inflict damage within. So we have a whole slew now of medications that act on the immune system, to try to normalize these immune cells or keep them from entering into the brain and spinal cord. These disease-modifying therapies are very, very important. We know that they're very important because for relapsing remitting MS, there's now very good documentation that as a result of the use, you can expect fewer relapses and also lower severity of relapses as well. 25 years ago, it's not uncommon for an MS attack to land a patient in the hospital for some period of time. These days, we actually don't really hear about the requirement for chronic stay in hospitals. So this speaks to how our MS medications have helped by not only producing fewer relapses, but also lower severity of relapses when they occur. And if one stops these medications, and this is an area that is still highly debated, for those relapsing remitting patients that have been stable for many years, do you go off medications or not? So there's no uniformity of opinion out there, but there are MS individuals that will have MS attacks when these medications are stopped. Again, speaking to the potency of these medications in keeping the bad immune system at bay, if you like. With regards to the clinical forms of multiple sclerosis, I alluded to relapsing remitting multiple sclerosis. So basically, this tells you the different forms that you might be familiar with. Here is increasing disability. We have the relapsing remitting form where you have one relapse returning to a baseline remission, and then there might be a second attack, so that this, and then returning, remitting. So this is relapsing remitting MS where there is remission in between attacks. In some individuals with relapsing remitting MS, at some stage it progresses, and this is secondary progressive MS. Some individuals have progression of disability from the beginning, and this is primary progressive MS. And I want to also refer to this one episode, which is clinically isolated syndrome, not yet MS, because you need a second event in order to call it definite MS. So these are the different forms. I've told you about the medications that we have used, that we have available now, the 15 or so approved by the FDA. These are for the relapsing remitting forms of MS. So therefore, what is challenging the field at the moment is the area of progressive MS. It remains very, very challenging. But I just want to tell you that there's promise. Last year, ocrelizumab was approved for use in primary progressive MS because in a clinical study that involved many different countries, including Canada, ocrelizumab or Ocrevus was found to help some patients with primary progressive MS by reducing their progression of disability. There's another medication that has been shown in clinical trials now, siponimod, to reduce disability in secondary progressive MS. This is now before the FDA, and we will likely see approval of siponimod in secondary progressive MS, we hope, next year. That said, there are a number of medications that have shown promise in smaller clinical trials that are sort of making their way forward in larger clinical trials. They include statins that some of us, like me, take to control cholesterol. This is high-dose statins used at much higher doses. And it has been shown in smaller trials to reduce the neurodegenerative events within the central nervous system. What I mean by that is you might have you might recall my earlier cartoons of the cells within the brain and spinal cord being destroyed by immune cells. So over time, that will result in atrophy, a smaller brain volume. As one loses elements within the brain and spinal cord, the brain will shrink. That is called atrophy. So statins were shown in a smaller clinical trial to reduce the evolution of brain atrophy in patients with MS. Here's another medication, lipoic acid. It's an antioxidant, also shown in smaller clinical trials to reduce the evolution of brain atrophy in progressive MS. So these are two, we hope that the results will be carried forward in larger clinical trials and hoping that, they will continue to show promise. In Calgary, we are testing hydroxychloroquine. This is an anti-malaria medication used in rheumatoid arthritis, so we know that this is a fairly safe drug when used chronically. We are testing hydroxychloroquine in primary progressive MS because in our animal studies, hydroxychloroquine is very effective in reducing some of the drivers of progressive multiple sclerosis, at least in animals. So we are testing this in a clinical trial currently. So I'm hoping that progressive MS will see the advancements that we know are occurring in relapsing remitting MS in terms of medications, right? You saw the slew of medications that became available for relapsing remitting MS when there's the realization that relapsing remitting MS can be managed. Now we know as we go forth in progressive MS that while challenging, that there is hope, something can be done about it, and we hope that going forth we're going to see more and more rapid advancements with regards to progressive MS. With that, I want to tell you about some of the activities of the MS Society of Canada, one of which is this activity that is called CAN-PROCO. It stands for Canadian Proactive Cohort Study for Canadians living with MS. It is a study funded by the MS Society of Canada in collaboration with Brain Canada and a drug company, Biogen. The overall lead is Dr. G10 that some of you might know, a neurologist at St. Mike's. CAN-PROCO is a national study. It's close to $10 million in budget. It is to occur across 5 sites in Canada, in Toronto, in Vancouver, in Calgary, in Edmonton, as well as in Montreal. So this is a pan-Canadian study focused at 5 sites across the country. The trial has just been funded. So the group of investigators led by G10 are just coming together to try to kickstart this. We're supposed to start this month, but we think we'll probably roll out in January. It involves a number of MRIs that will be followed on a yearly basis. Will also involve blood being collected on a yearly basis. This is over the course of 5 years. The scientific goals is to try to understand what drives progression in multiple sclerosis. Not just looking at one single factor, but across a multitude of factors that you can see here. So this is a study then to evaluate many of these factors that drive the onset as well as the rate of progression of disability over the course of 5 years, with the hope that if we learn about these factors, we can ultimately do something about stopping those factors. And those factors that are going to be studied include biological immune cell factors. They include microstructural brain changes as evaluated using MRI. They will involve the type of treatments that one uses, the demographics such as the genetic background. We'll be looking at health systems, environmental, and the like. And here I want to point out Melanie. Melanie, would you please stand up? Melanie is our lead research coordinator of this pan-Canadian CAN-PROCO study. So Melanie will be available during lunch, hoping to give you more information and perhaps to sign you up as well for this pan-Canadian study where you will be followed on a yearly basis. And the plan is to recruit about 1,000 patients across the country, follow them for 5 years, evaluating all of these factors in order to try to understand what drives progression in Canadians living with multiple sclerosis. And what, in those that do not progress, why is it that they do not progress? What are some of the positive highlights that we can capture out of this in order to lend new knowledge going forth on how to reduce progression of disability in multiple sclerosis? So I want to acknowledge the strong support of the MS Society of Canada that coordinated and recruited in the other funders in order to provide this study for the national population. One more thing that is occurring and led out of Canada and also funded by the MS Society is this study led by Anthony Feinstein, also based here at the University of Toronto. And this is in progressive MS, and asking whether or not cognition that does occur in MS, the not thinking clearly, the not thinking as fast anymore kind of things, whether or not this cognition can be improved by cognitive rehabilitation. Just like you have physical rehabilitation, this is cognitive brain training, rehabilitation, and also aerobic exercise as well. Exercise is known to confer a number of benefits in health in general in multiple sclerosis. And this is a clinical trial actually occurring across 6 countries, if I recall that correctly. Yes, as it says here, 6 countries, 11 centers, in order to try also to ultimately reduce the cognitive decline that can occur in multiple sclerosis. I want to tell you about yet another advance that I have had the privilege to be associated with, and this is Minocycline. Minocycline is a tetracycline antibiotic commonly used in the treatment of acne. About 18 years ago now, we discovered that minocycline is actually an immune modulator. That minocycline is actually quite effective at keeping immune cells from becoming activated and reducing their ability to enter the brain and spinal cord in large numbers. We were also able to show about 18 years ago now that minocycline would reduce severity of MS-like symptoms in mice given minocycline. So this then, as I've said, it inhibits immune cells. This then led to a clinical trial in clinically isolated syndrome. So the trial funded by the MS Society of Canada is to ask whether or not after a single attack, not yet MS, but highly suggestive of future MS, so this is called clinically isolated syndrome, whether or not the use of minocycline would reduce the acquisition of a second event and therefore multiple sclerosis. So this study that started from the lab was then brought to the attention of Dr. Luann Metz, my neurology colleague at the University of Calgary. I'm a scientist. Luann Metz is a neurologist, and we have been collaborating for many years now on bench clinical expertise in order to improve outcomes in MS. So this is a $4.1 million study funded by the MS Society of Canada that was published last year, actually, in clinically isolated syndrome. And basically what it shows is that over a 6-month period, the rate of conversion from CIS to MS was lowered from 61% to 33% by minocycline. So what this means is that if one has a CIS, potentially becoming MS down the road, if one goes on minocycline over that 6-month period, the risk of acquiring a second event is actually lowered by half. So this shows that minocycline is useful in CIS to reduce its conversion to multiple sclerosis. And I want to bring up this one slide that you cannot read from the back of the room. It talks about the cost of MS medications in the United States. I can't read this either, but I'm going to try to remember the gist of the story for you. So basically, this is the cost of these medications in thousands of dollars in the US. And here are the years in which these medications were introduced into MS use. So from the very beginning, when the first medication was introduced, the medications were already at $10,000. And then over the course of this 20 years, and this is just finishing somewhere around 2015, now the average cost of all these medications in the US is about 50,000 US dollars per year or more. So MS medications are not cheap. In the US, they are about $50,000 per year or more. Here in Canada, 15,000 Canadian or more, depending on which medication you go on. And here's minocycline coming in at $600 a year. And that's because it's a generic medication, has been around for a long time, and it comes in at about $600 a year. So in Calgary, when one comes in with a CIS, suspected potential future development of MS, they now go on minocycline treatment in order to protect them in the first while. Because you may know that in order to go on MS medications that cost a lot of money, there needs to be an approval process, an application process, and now there's, at least in Calgary and a number of other clinics across the country, the use of minocycline soon after one comes in with a CIS. And in fact, we're trying to develop plans to have minocycline available even at the GP level when one comes in to the GP with what might be suspected CIS. So we'll see how this develops. But meantime, our colleagues in a number of areas of the world that cannot afford MS medications are beginning to use minocycline for MS. You know, even a country like China, quite affluent, you might think. Well, my colleagues in China tell me that all the MS medications that we have talked about are not available in China because they're just too expensive. And so now in China and in many other parts of the world, we hope that minocycline can be available, and indeed some of the practitioners are using minocycline for MS in other parts of the world. So this, I want to thank the MS Society of Canada for having funded this study, actually all the way through from our first laboratory study on this in 1991, all the way through the phase 3 trial of minocycline. So yet another advance in MS that I want to talk to you about is the repair of myelin. No, I'm good, thanks. So here you're looking at these nerve fibers coming out at you. Here's one nerve fiber, another nerve fiber, and you see this wrapping around it. That's the myelin wrapping. In MS, the myelin is lost, and so you don't see those wrapping anymore. But here is remyelination that has occurred. So the reacquisition of this myelin, they tend not to be as thick, and that's why we know that this is remyelination rather than spat from injury in the first place. Despite not being as thick, we know that it is completely functional. This is remyelination. So the goal of remyelination, therefore, is to try to regain the regrowth of these oligodendrocytes so that these cells can then be promoted to re-extend all these processes in order to reform myelin, in order to regain some conduction of messages and hopefully some recovery of some deficits. This is the goal of remyelination. And here I just want to impress upon you that we can visualize these oligodendrocytes that make this myelin at very, very, very high resolution. Here we are looking at one single oligodendrocyte, and I'm going to rotate this in a very short while, but it starts from here and it forms all of these processes, and these processes will then contact axons. This is what makes myelin. So one oligodendrocyte makes multiple myelin sheath, those myelin insulator, often located on many different nerve fibers in the brain and spinal cord. That's why MS is so devastating. When one loses one oligodendrocyte, one loses a lot of myelin that single oligodendrocyte forms. Can you start this video for me, please? So again, one single oligodendrocyte and its multiple processes and myelin segments that it's forming. So just to show you that we can look at these cells now in very, very, very high clarity. So the good news is that these cells are actually preserved to some extent in many MS lesions. So here is a very chronic lesion, a plaque in a case of multiple sclerosis. By all intent and purposes, this is a very old scar. But the good news is that these cells that are needed to reform myelin are still present. Here is a blow-up of one of this with its multiple processes that I just showed you in the last video. So that's the good news. Because if these cells are retained and preserved to some extent, then there is hope for us to make this regrow and remyelinate. So that's the goal of remyelination. And along that line, because of that glimmer of hope, there's now actually a number of clinical trials of potential medications for the repair of myelin. The most advanced is this medication called antilingo, also called opicinumab, that Biogen IDEC, based in Boston, is driving. This is a treatment to try to make the environment for repair of myelin more favorable so that that repair process can occur. But the Mayo Clinic is also testing one. The UC San Francisco also testing another one. And at the University of Calgary, we're also testing yet another one. So there are a number of trials ongoing on remyelination, where the goal is actually not just to control the immune system, but actually to try to elicit recovery. So, lots of exciting things happening in the field of MS research. Not only do we have a lot of disease-modifying therapies, we are also now entering the area of remyelination, the repair of myelin. But I want to take a few minutes and share with you a question that we set out to ask, again funded by the MS Society of Canada, and that is whether or not lifestyle can promote remyelination, and specifically whether or not exercise can promote remyelination. This study was done in mice, where we have to start most of our investigations first. But we do know that exercise confers well-being in multiple sclerosis. now a lot of data sets and publications showing that if you remain physically active, you generally will fare better. And even though you are expending energy doing exercise, the surprise is that exercise is actually good for fatigue. So we want to encourage you to stay healthy. And the other motivation, if you like, is this data set that exercise can actually promote myelin repair, at least in animals. So the study then involves the use of this molecule called lysolecithin that is injected, in this case, into the spinal cord of mice. It produces this discoloration, which is actually the loss of myelin. So this is demyelination. And this particular model is quite nice because in the uninjured scenario, you have all of these nerve fibers coming out at you, and wrapping around them is this green myelin, where very early on you lose that myelin, so that's demyelination. But over time, there is spontaneous repair of some of these nerve fibers, remyelination. In animals, just as this, we know now, occurs in multiple sclerosis as well. So the question is whether or not following that demyelination, would exercise promote that repair? So again, mice are subjected to this injury, and after injury, mice are returned to the cages for recovery. We allowed some mice to exercise. They have free access to a running wheel. So this is voluntary running as much as they like. And non-exercising control demyelinated mice have a running wheel that is locked, so they're unable to run after that injury. Here's some data set that looking directly into the lesion, looking at the cells and the oligodendrocytes that are reforming. We have exercise in animals increasing the number of oligodendrocytes that are needed to make new myelin. More importantly, when we look at myelin itself, shown here, where here's again a nerve fiber coming out at you, the myelin around. In animals that are not allowed to exercise, they still have a lot of nerve fibers that are not remyelinated, shown in this pink color, whereas in exercising mice, many of these, shown in green, have new myelin on them. And when one looks at the extent of this new myelin that is formed, here's exercise promoting remyelination. We published this work actually about a month ago. The MS Society actually has it on its website as one of the research that it's reporting. So, in short, in lesions of exercising compared to non-exercising animals, 2 weeks after injury, we have this more oligodendrocytes and 2.7-fold more remyelinated nerve fibers. So exercise promotes repair. So exercise is not just good for general well-being, but for us, exercise promotes repair, and I'm hoping that this can be a strong motivational point. Many of you are strongly motivated, I know, but exercise is good. Exercise promotes the repair of lesions. MS societies these days, including the MS Society of Canada, advocates exercise. About 40, 50 years ago, MS individuals were told to remain quiet. You don't want to use unnecessary energy. You want to conserve your energy. But now a lot of data sets showing that physical activity is good for cognition, cardiovascular functions, good for fatigue, and I'm telling you now, at least in animals, good for the repair of myelin. So the MS societies now are advocating keeping healthy. You don't have to bust your guts, the MS societies would tell you. Just remain active and do whatever you can, and stay, stay active. So the research then is towards a more active lifestyle. I want to encourage you for that. what we also know from our animal work is that exercise also improves the anti-inflammatory immune cells that we have. That we think also contributes to the well-being of exercise in multiple sclerosis, besides the repair. All right, so moving towards the end now, yet another advance that I just want to tell you about is that the study of stem cells in MS continues at a very rapid rate. I know that last year's speaker was Mark Friedman from the University of Ottawa. Mark Friedman, through funding from the MS Society of Canada, conducted this study. It's called the Canadian Hematopoietic Stem Cell Transplant Study. This was for aggressive multiple sclerosis. Here, they're looking at clinical signs, and I'm showing you before the stem cell, where you see a lot of red circles, a lot of relapses in these individuals, very, very aggressive MS. Each of this line is a single individual. So here's an individual with X number of relapses in red, another individual here, yet another individual. So this is all before stem cell transplant protocol and after. Look at this. You know, many of the red circles are now gone. So this trial showed that this very aggressive therapy for very aggressive MS was useful in reducing relapses, and moreover, very useful in reducing the number of MRI lesions as well. And the group also went on to show that in some individuals, there's actually improvement in the extent of physical disability. So again, here's before to the left, and this is after the treatment. Each of these line being a single individual, so that here's before and after. Some of these patients have actually recovered some of their deficits. So for me, you know, I'm encouraging the MS Society of Canada to try to change its mission statement, to make it more bold in terms of including the word recovery in the mission statement. And I'm hoping that, you know, as we go forth, that's what we'll see. You know, immediately things do not happen quick enough. And I, on behalf of the research community, would tell you that we move at a very, very slow pace. But it's also necessary, because anything that we do has to be safe. You know, it's a very slow process. We need over and over again to ensure ourselves that what we are saying is indeed correct and also safe as well. But for me, working in this field of remyelination in particular, I see a lot of very promising signs. So there are other types of stem cell therapies that are being done as well. The one out of Ottawa by Mark Friedman involved stem cells from the bone marrow. Here are other types of stem cells, mesenchymal stem cell, that one can even get from adipose fat tissues through liposuction. There's also this technology of inducible pluripotent stem cells, and also the use of precursor cells to oligodendrocytes, or another area that we are involved in, and that is to use drugs that can enter into the brain to promote the brain stem cells to reform new cells. So that's another approach that is being done. So here's my final slide then. Want to leave you with a number of thoughts today, and that is there are many advances occurring in multiple sclerosis here in Canada as well as around the world. A lot of research activities. I shared with you new insights on disease and lifestyle modifiers. I told you about many medications now for relapsing remitting MS, but that medications are being increasingly tested and becoming available for progressive MS, that there is the potential of repair medications, certainly a lot of research ongoing in labs, and some of these making their way into early phase clinical trials. I told you about physical activity, exercise, promoting not only well-being, but also the prospect of repair. I want to encourage you to stay positive and hopeful. There's another area of research that I did not tell you about, and that is the basis of mind over matter. This actually comes out of a lab based in Israel. And I actually wrote this, a letter of reference for that researcher who is being nominated for an award. And that is, there is a good biological basis for positive thinking and how the immune system becomes affected as a result. So there are some biological mechanisms that are being worked through. So stay positive and hopeful. And I want to end by myself acknowledging the MS Society of Canada for actually many years of research funding. My first research grant from the MS Society was in 1991. I also get a lot of research funding from the government of Canada as well. But the MS Society has been there all through, and it has funded many of the big trials that I've told you about, the Minocycline trial, the Ken-Proco new study, the cognitive rehabilitation study of Anthony Feinstein. It is the major funder of research activities on MS, more funds than what the government of Canada provides. And it certainly has been there driving many of these research advances that I've told you about. So with that, thank you very much for your attention.
So thank you so much, Dr. Yong. And we're going to have, can you just put, Paul, the slide up regarding the email address? And I've been getting some emails in, so I appreciate that. Joanne and Maheen are going around. If you've written down your question and you wish to hand it to them, we have quite a few. In the exhibit hall, if you have a question, please give it to Jennifer, or again, email me if you wish to the email address. And we'll get started in 2 seconds there as people get settled. I really felt, though, what you spoke about, the importance of exercise. And we've been hearing about that for some time now, but it's the doing it, isn't it? And so it's very encouraging to hear that if mice can do it and feel better, then we should be able to get active. So, all right, so here we are. We're going to start the questions. Oh, my goodness sakes alive. I'm going to have to weed through some of them. So my first question is about vitamin D, and I'm assuming that we're going to have maybe a few of those. And I'm very excited to report that this week the MS Society has just posted some tremendous guidelines and protocols related to vitamin D. But with that said, if someone is taking a couple of thousand, say 2,000 of units of vitamin D at dinner time, but they want to take 4,000, is it best to split it up over the day or take it all at once? Any idea about that?
Well, our clinic recommendation is to take it all at once. I mean, there's no reason to split that up over the course of the day. Vitamin D does accumulate steadily over time. So, just taking it all at once would seem more logical than splitting it up, because everything is going to accumulate in the body over time anyway.
Okay, thank you. Are you able to speak anything about stem cell transplantation and the connection with brain repair related to age or disability? Now, I'm going to put you on the spot for 2 seconds, and Mel and Maheen, I'm definitely going to put you in the spot. So if there are some questions that you feel that you can't answer because there are other research in order, or whatever. Dr. Ruth Ann is not here at this point. Maheen might be able to answer. So, what can you share about stem cell transport and the connection with brain repair related to be the age or disability?
Well, age is actually a very interesting area of research. You know, not surprisingly, with age, and as I'm aging, I can feel it as well. You know, everything goes down a few notches, and with age, repair is also not as robust as that could be occurring in a younger individual. So with regards to MS, we know that the further along we are in age, as well as the further along we are in years of MS, we are not doing or repairing as well as earlier on in the disease stage. That said, a number of the reasons why age is not as effective in promoting repair are being discovered, and strategies to try to promote the aging deficits in repair are also ongoing, at least in lab studies.
Thank you. I've had two questions about minocycline related to its use for people with CIS to reduce the possibility of developing MS, but how effective would it be for those already diagnosed with MS? And can it be used alongside, say, one of the other DMTs or other medication? What studies can you speak to about its use in conjunction with other medication?
So at this point, there are very, very few studies outside of the CIS trial. But what we do know is that in the CIS trial, where we use an older criteria for defining what CIS is, now with the newer criteria, the newer McDonald criteria of MS, some of those CIS patients were actually already well in the relapsing remitting MS stage, albeit early relapsing remitting MS. So therefore, you know, it's fair to say that we only have good data for CIS, although some of the individuals in the CIS trial were already early relapsing remitting MS. With regards to more established MS or progressive MS, we don't have any clinical trial information at this point. Can't really make any recommendation. With regards to combination treatment, we have published on combination treatment in animals, in which mice with MS-like disease given minocycline with an interferon beta or with Copaxone actually fared better than mice just given those medications alone. We have actually a phase 2 trial, a very small trial of minocycline in combination with Copaxone, where the combination looks much better than just Copaxone alone. So again, you know, in the absence of more data sets, it's very difficult and irresponsible for us to make recommendations with regards to combination treatment at this point.
So another question about minocycline then, can you get a prescription if your doctor doesn't want to give you a prescription? So how can you go about getting a prescription? Actually, I have some in my bedside drawer because they really made me not feel very good. So I didn't take it.
Well, you know, you just have to speak to your doctor and make your doctor aware of the information that's available in MS. Luann Metz, who is the lead author of the minocycline phase 3 trial in CIS, is actually trying to bring on board recommendations that will have minocycline potentially being more understood and potentially more available for MS, but that will take some time to unfold.
How can I know I have CIS, or how can it be identified? How do you know?
You know, here I'm not a clinician, I'm not a neurologist. There are some clinical signs and also some MRI parameters that help with the diagnosis of CIS.
Okay, thank you. Sorry, I'm just getting my, what's the probability of having a relapse after the age of 60? Is there any data on that? If you've stopped taking beta-seron after 25 years or so, is it possible then to have a relapse? Any data on that? Or on relapsing remitting MS as well. So probability of having a relapse after 60, if you've been, I assume, having MS for many, many years, in this case 25 plus years, and then stopping the drug, what happens there?
Yeah, so this is where, at this point, there's no unanimity, no recommendation for whether or not one should stop treatment after many, many years of stability and as one ages. You know, the immune system is supposed to age and become less aggressive with, in an individual with MS over the years. But that said, there are documented cases where after many years of treatment and stability, stopping a medication now results in some individuals having relapses again. So it can happen. We just don't know how often it will happen. We don't know why it would happen in some but not others, but it can happen.
Thank you. Any drugs do you think of, is there any hope for drugs in the future to repair the myelin beyond the mouse studies?
Well, the 4 clinical trials that I've indicated to you, the anti-lingo or opicinumab being the most advanced out of Biogen IDAC, they have already done a phase 2 clinical trial. The process of clinical trial is that one begins with a phase 1, which is a safety trial, and then if the drug is deemed safe, that then goes on to a phase 2, which is to obtain preliminary evidence of some usefulness. And then from a phase 2, one goes on to a phase 3, which is a large clinical trial, a definitive clinical trial to now obtain evidence of efficacy. And for multiple sclerosis, we need 2 phase 3 trials for medication to be approved by the FDA. So for the anti-lingo trial, that's already in a phase 2. The company is doing a second phase 2 at this point because they think that they need to sort out a few more details before going into a phase 3. And then the statin trial, driven primarily out of London, is in the phase 2 stage. The lipoic acid occurring in a few centers in the US, also in the phase 2. And our domperidone trial, that is an early phase 2A.
Thank you. I've had some questions regarding the gut and micro. Can I hold those questions off until Dr. Walter speak, please? Unless you have a question and you have to leave before you hear his speak, I'm going to leave anything related to gut health to him. Please bring up the slide again if you can about the Rebif. After 20 years of being on the market, what are the long-term side effects? That's number, or can you speak to that if we can't get to the slide? Also, okay, let's answer that one first. Rebif and long-term effects after, say, 20 years. Any record on that?
Well, many of our long-term medications like Copaxone or Rebif, after a very, very long term of use in many individuals, still continue to hold safety, very, very well. Not every medication works for every individual, and there's some peculiarities of the immune system that we still do not quite understand. Why is it that some patient will fare better on one versus the other? But in those that have fared well on our long-term medications, they have continued to do very well without the need for the neurologist to switch them to anything because of persistent side effects or things like that.
Thank you. Clinical trials are often designed to recruit participants under than 50 or so, but yet many people live longer with MS. So why are trials not recruiting older participants?
Well, yeah. So that actually is a very good question. The fact about doing a clinical trial is that you want the best possible chance for that trial to succeed. And so therefore, you want your study population to be as confined as possible, with as few variables as possible, to have the best evidence of glimmer of hope that that medication is going to be useful. And that's why most trials are done with a very select population, following which, it then becomes more readily available ultimately to the population at large. But initially, just to make sure that you get the best possible information, you have to be, unfortunately, as selective as possible.
Thank you. A lot of questions about cannabis and MS, which I'm not going to take a lot of time right now, unless you have something you wish to say about it, Dr. Yong. We have a lot of material on our website. I will send a link out when I send the evaluation with all the advice, protocols, and details on that. Is there anything, though, you want to say as a blanket statement? But I will send out the information. And we have a lot of webinars we've done recently as well on that, so I'll send all those links.
Right. What I do know is that some of my colleagues are very favorable with cannabis in MS and some less so. In animal studies, though, in animals that develop spontaneous multiple sclerosis, there's some good literature around the usefulness of cannabis.
Oh. On your slide regarding the stem cell therapy, what did those little red dots mean again? And not all had dots after on the other side. Can you explain that again?
So those red dots referred to the number of relapses before stem cell therapy. And then the lack of red dot after therapy refers to relapses being stopped. So an individual before the stem cell therapy had many red dots, many relapses that went away after stem cell therapy. That's the study of Mark Friedman.
Brain atrophy, does it happen in everybody as we age or just people with MS?
It happens to all of us, more so with MS.
Okay. Sorry, 1 second here, I'm just catching up. Can you repeat again, hydroxychloroquine? How I can't say that. Can you please recap how this drug is used and what the results are to date? You know what I'm saying, right?
This is hydroxychloroquine.
Thank you.
This is a safer form of chloroquine. Hydroxychloroquine or chloroquine are anti-malaria medications. If you were to go to Africa or the Far East, certain places in the Far East, you might be asked to take anti-malaria medications. That would be hydroxychloroquine or chloroquine. It has anti-inflammatory, besides the malaria control, it affects the immune system. And that's why the patients treating rheumatoid arthritis have used hydroxychloroquine for many years. And one of them pointed out to us that hydroxychloroquine has good anti-inflammatory activity that potentially could be useful in MS. We went on to do a study in animals to show that hydroxychloroquine would be useful. And from those animal studies, we have now evolved into a trial that is ongoing, led by my clinical colleague, Marcus Koch, at the University of Calgary. It's a trial of hydroxychloroquine in primary progressive MS. So it's ongoing at this point. And the question is whether or not there would be any evidence that hydroxychloroquine would slow the accumulation of disability in primary progressive MS.
And to carry on with drugs, Aubagio or teriflunomide, what type of medication is this? Is it to reduce cells, modify cells, kill cells? What's it doing?
Yeah, so Aubagio teriflunomide would reduce the proliferation of the immune cells that are overactive in multiple sclerosis. So it would, according to the schematic that I put up, would result in reduction in the number of those bad cells, if you like, by preventing their multiplication.
We've had a few questions about heat in MS, be it exercise, hot water, hot weather, etc. Can you comment in general on mobility issues related to what's the effect of heat on MS and why?
So in the cartoon that I showed you about transmission of message from one nerve cell to the other, the transmission of and how one talks to the other, with the disruption of myelin insulator, the transmission is not as smooth or sometimes impaired. With exercise and heat, that transmission can become somewhat aberrant, even worse than what would have been in the first place. So that's why heat can sometimes lead to what might be called a pseudo relapse, or some clinical worsening, but that really is due to the disruption or interruption or interference with the smooth transmission of message that goes from one nerve cell to the other. And the that said, so that would be the biological basis of heat-induced apparent exacerbation in some cases, which goes away when the body returns to normal heat.
Thank you. Yes, the slides and the recording will be available again to everyone later. I'll send that out in a couple weeks or so. You get the slides and the audio side by side. So for those who are asking that question, you will receive everything. You made reference that some people with relapsing remitting MS advance to secondary progressive. It is used to be considered an inevitability. What percentage, though, today will progress to secondary with the new treatments that have been made available?
That is a very good question. The older literature would indicate that about 80% or so of patients with relapsing remitting MS would expect to progress into secondary progressive MS. With the new medications that we have, we know that these medications reduce the number of relapses, and often consequent to that, the disability also does not progress as fast. What we do not have are actual numbers in terms of preventing conversion to secondary progressive MS at this point. But the thinking is that there likely is a reduced propensity to progress into secondary progressive MS as a result of controlling some of the early events.
So we've had a lot of questions about exercise, how much you should exercise. Why do mice seem to do better in exercise than we do in exercise? So all these questions relate to exercise. So again, I will send out some great materials that the MS Society produced on protocols related to exercise. Did you want to stress anything more, though, about why this is so important?
Well, the recommendation, if you go onto the websites of the MS societies around the world, would be, do what you're comfortable with. You don't really need to bust yourself. We don't know at this point how much exercise we actually need in order to induce profound repair. Actually, we don't know at this point. We need to do that study in humans. We need to have an MRI study of some sort in order to look at objective evidence of myelin repair with exercise in MS. The indications from animal work would be that it can, but we don't really have that information. And generally speaking, most of the practitioners would tell you just, do something, do what you are comfortable with. But often at times you also heard of the people who, do the bike rides, the MS bike ride from one place to the next, the people who stay very physically fit. And often at times you would hear that those are the ones that actually seem to do really well.
And along the lines of diet and exercise, is it part of the CanPro-Co study?
The CanPro-Co study will collect as much information as possible with regards to clinical, lifestyle factors, all these kinds of information.
Another question about medication, cyclophosphamide, is it still an option for patients with MS?
It's a very old drug. It is a drug that is an anti-cancer agent. It will kill immune cells and prevent their multiplication, and therefore reduce the propensity of immune attack on the brain. Most would not use cyclophosphamide unless there are no choices. Many of my colleagues in China actually still use cyclophosphamide because they do not have other things, many things available to them.
Can you clarify again CIS? What exactly is it?
Clinically isolated syndrome, or we call it the first demyelinating event, the first attack, if you like, but not quite MS yet, because we need a second event in order to, for the diagnosis of multiple sclerosis. And usually in CIS, our neurologist colleague would be able to sort of predict with some confidence probability whether or not there would be a second attack based on the number of MRI lesions, for instance, at CIS. But basically, it's the first event. Well, having said that, it's the first obvious event that one can detect clinically. We actually think that MS goes even before CIS. So CIS is the first clinical manifestation, either in terms of a relapse or, a relapse of some sort. But there's also a phenomenon called RIS, which is radiologically isolated syndrome. A person comes in with a migraine or suspicion of a brain tumor, let's say, or some head injury of some sort, concussion, needs an MRI, and spots are seen in the brain, but there are no manifestation of any clinical signs. So that's called radiologically isolated syndrome. That and other literature leads us to suspect that MS actually begins, even way before RIS or CIS, the first clinical manifestation. And actually the challenge is to detect MS as early as possible, because all the data tells us that the earlier we treat MS, the better the longer term prognosis.
Okay, so some questions about the influence of ethnicity or other race factors, i.e. Scottish or white Caucasian, etc. So that the reality of ethnicity in MS.
Right, so, it's very interesting. I mean, if you think about Orientals, well, we have Orientals with MS, but the frequency of MS in the Orient is less than in Caucasian populations, even when you take the same latitude, temperate, and lack of vitamin D into account. And then you have also African blacks that, Africans that seem to have a worse cause of MS when they get MS, even if the incidence is not as high as Caucasians in the first place. So that speaks to, some genetic predisposition and also the role of some genes that regulate, we think, immune responses in multiple sclerosis.
Okay. Secondhand smoke. So you're not a smoker, but your partner or your family, or you grew up in a home with secondhand smoke. How could that affect your development of MS?
Yeah, it's actually very interesting, and studies have been done along those lines. And secondhand smoke actually do also increase the risk of developing MS. There are more MS cases amongst those exposed to secondhand smoke, and that's in the literature.
Okay.
So your partner is not doing you a favor.
Sodium bicarbonate, baking soda. Is that the same as salt, considered salt, and does it affect MS?
No, I'm referring to sodium chloride in particular.
Okay. Why is it sometimes your MS affects, say, the right side over the left side, and other people it's reversed?
Well, it depends on where the lesions form. And at this point, we don't really understand why lesions form in certain areas of the brain and spinal cord more preferentially than others, and why it differs from one individual to the next. But depending on where those lesions form, that will dictate where the symptoms manifest.
Could you comment on what is going on when mobility is markedly improved under cool to cold conditions, especially late at night? Is the myelin sheath somehow puffed up to improve the neural connections?
No, it would be in the context of the, just like the heat-induced irregularities of transmission of impulses. There's a person who described this phenomenon. His name is Utov. It's a Russian-sounding name, so this is the Utov phenomenon. And he describes that the reason for symptoms with heat-induced is because of the heat-induced irregularities in the movement of impulses down nerve fibers. And so therefore, if you're in the cold and you don't have that issue, you tend to do better.
I've had some questions about stress, be it a connector to diagnosis of MS or worsening of symptoms, as well as things like life issues, concussions, etc., any traumas on the body. Is it connected to a diagnosis of MS?
Well, stress, I told you about this Israeli researcher that I wrote a letter of reference for recently. Her impact on the world actually is on the biology of how positive thinking and therefore stress affects immune cells and well-being. So there's some connection between therefore stress and impact of immune cells, and there's even more biology to that in terms of regulating the activity of those immune cells as well. So,
I think this is a pretty neat question. They're all neat, by the way, but this one's kind of neat. So can you speak to how MS, and this is what I understand the question to say, how MS changes possibly as we age, so that our immune system is impacted with our age process, and how that can connect with the diagnosis of MS and all the issues? I think I got that right.
yeah, it's actually a great question. So I spoke about the aging of us and how things go downhill. The immune system also ages as well and becomes less robust. So we are less able to fight infections with aging, for instance. So with that, if you think about MS being immune focused, why shouldn't MS go away with aging? Well, it does not, because there's a literature around the type of immune cells that become engaged with aging in MS or with progressive MS, so that for the early relapsing remitting forms of MS, lymphocytes, a type of white blood cell, seem to be more important. But with longevity and with aging, the innate immune system that include monocytes, macrophages, those now become engaged. So there's a switch of involvement of the type of immune system with longevity and also aging. And so those are actually very active areas of research in terms of trying to counter the type of white blood cells that come into play with longevity and with aging of MS.
Are you able to speak to the flu shot? And should someone with MS get the flu shot? Or the reaction to the flu shot?
Not very well. Our clinic do not have issues with vaccination except for those with those involve live vaccine. Maheen, you have anything to add to that?
And Dr. Ruth Ann will be speaking after lunch, so we can ask her that question.
Yeah, ask Ruth Ann that.
Okay.
I was hoping that she'll be here to fan off some
Yeah.
questions, but
Okay, questions about men being diagnosed with primary progressive MS, generally more than just starting with relapsing, and where are we at with either specific research into men and progressive MS? Where's research sitting on that?
so it's a great question. We know that gender is at play in sex is at play in multiple sclerosis. For relapsing remitting form of MS, there is 3 times or 4 times as frequent relapsing remitting MS in females than in males.
Yeah.
But for males, primary progressive MS seems to be more predominant. At this point, we don't understand why that is the case.
Thank you. I am going to give some of the questions that we've received right now to Dr. Mary because they're more specific to what she'll be speaking about. I have to maybe stop now the written and the email questions for this period. We can take that one, Maheen, if you think it's appropriate. Otherwise, I'll be making sure Dr. Mary gets some of these questions. Okay, where are we at here?
The questions have been very, very good.
They've been very good. That one's
Yeah.
that's a Dr. Mary question. Okay, minocycline again. Should people be taking minocycline as a prevention for their children? Let's say that they have MS, but they want to prevent it. Is it one of those drugs that can be used for that purpose?
Don't think so. My clinical colleague, Luann Metz, who drives this clinical trial of minocycline, would not advocate that. The long-term consequence of minocycline includes discoloration of teeth, and we don't really know, what else. In the MS trial, over the period of study, which is 2 years, minocycline was very well tolerated, with the exception that some individuals get discoloration of the teeth. So therefore, in kids in particular, we would not think of minocycline as a potential prevention strategy. That said, many of our clinical colleagues would advocate vitamin D in families with children at risk for multiple sclerosis. The good data in terms of safety, it's not completely clear what dose we should be giving for those children at risk because of genetic history within the family, but vitamin D would be the route to go rather than minocycline.
Thank you. And I'm not going to answer a lot of questions or ask a lot of questions more about vitamin D. Quite a bit has come in for that, but we will address that when I send out the email and all the details that we have on our website just posted. Blood-brain barrier. We hear about these cells crossing over and they're not supposed to, hence the name barrier. Is there any actual research into why this occurs, or is it all reactive research instead of proactive?
No, there's a lot of research ongoing about the breakdown of the blood-brain barrier. A lot of research in terms of understanding how immune cells adhere onto, these white blood cells, immune cells, are flowing very, very rapidly in blood. They're just streaming through. And yet, in multiple sclerosis, many of these are able to stick onto endothelial cells of blood vessels. And so there's a lot of research ongoing in terms of trying to understand what some of those adhesion processes involve, and also the use of medications to try to block those adhesion. A lot of research also ongoing on after the adhesion, these white blood cells produce enzymes that break down the blood-brain barrier. A lot of research ongoing there, and then also research ongoing on how to shore up the integrity of the blood-brain barrier to prevent its breakdown.
If the myelin is able to regenerate through drug therapy and you go off the drug, do you lose that regeneration, or do you need to then stay on that drug for life?
Well, what we understand from neuropathology of MS, which means, the many cases that have been donated to brain banks is that attacks or the formation of lesions can be, quite protracted and long-lasting, and that's why we would advocate treatment and continued treatment for long periods of time. And with that, there's also the appreciation that some of the newly repaired myelin that occurs in MS are also subject to new attacks as well by the aberrant immune system. So for medications in MS, we will have to go on it for a long period of time, not only with regards to those that quiet the immune system, but also those that help with the repair responses. It's an ongoing battle that one just needs to continue to foster.
And do you have a sense of how long remyelination occurs after demyelination?
Yeah, actually, that's a great question. In animals, it occurs within days following a demyelinating event, and we think that that's also the case in MS lesions as well. That soon after a relapse, attempts at repair are already kicked in very early on after an attack.
And does diet have any effect? Now, this might be something that Dr. Walter can also speak to later, but does diet have any effect to blood-brain barrier, improvement of strengthening that barrier, diet?
Well, Dr. Walters probably has more to say about that, but what we have an interest with in our lab actually is not only the gut flora, but actually what we call the breakdown of the intestinal barrier. So not only is there something about the gut flora, but there's also something about the leaky gut, and some things that leak from into our circulation from the gut now goes into the brain, and also at the level of the blood-brain barrier to disrupt that barrier. So that is actually an emerging area of research.
Sorry, I'm just going through. I do have a few questions that I am going to put aside for both Dr. Walter and Dr. Mary for this afternoon, so please be patient on that. I'm just going through this one, though, just a sec.
You should compliment yourself for
These are great questions.
being a very educated audience.
Okay, so in regards to genetic editing or possibly testing is maybe what the question is, to ensure that our babies aren't born with MS. That's
No.
number one. Is there a way to check genetics?
No.
So back to the vitamin D and doing other preventative type
Right.
of services. Is there discussion around hormonal therapies as associated with pregnancy? Because we know that there is some dampening of the immune system during the pregnancy stage.
Yeah.
Hormonal therapies?
Yeah. So this knowledge that pregnancy is actually good for MS because there are fewer relapses during pregnancy has led to a lot of research around the role of hormones in and their effect on the immune system. And what is being appreciated is that very high levels of estrogens, for instance, attained during pregnancy actually quiets down the immune system, and that helps account for pregnancy-induced well-being. That has led to clinical trials, particularly one that is in phase 2, driven out of Stanford University, of high-dose estrogen in relapsing-remitting MS.
Thank you. Vitamin K, can you say anything about vitamin K? Or again, is that something, Dr. Walter, you can talk about? No. Can you say anything about vitamin K?
Not very much, only because the literature around vitamin K and why that could be useful in MS is not very clear. There is some data about vitamin K and the formation of myelin, but that data set is not very good.
Mm-hmm. Oh. Can you store your baby's stem cells, so the core stem cells, core blood stem cells, for future research? Or can you provide that to a research team? This is a question we've had about brains too. Like, can you give your brain to research? Hopefully not today.
Yeah, brains for research are actually really valuable. Donations of, brain samples, and I can see some usefulness of cord, stem cells down the road.
Okay. You mentioned Ocrevus in your talk. Is there anything more that you want to speak to that, or I'm not quite certain what was missed in what you presented. Is it becoming, though, more common now to be used, and what are the results currently showing?
Ocrevus is this therapy that depletes B cells. In clinical trials, it has been shown in relapsing remitting MS to be much more effective than some of our current medications. Rebif in particular was what it was compared to in clinical trials in relapsing remitting MS. Also went on to a trial in primary progressive MS where a proportion of patients had reduced progression of disability. The downside, if you like, of ocrelizumab is that it's a very expensive medication, and we are still somewhat worried about the long-term impact of chronic depletion of B cells.
Okay. You mentioned about what you're testing on remyelination in Calgary. Do you have a sense of when that's going to be available to be used? Did I get that right?
Yeah. So this is the trial of domperidone in multiple sclerosis, where we are trying to look for a repair signal. The reason for using domperidone, which is this champagne that you drink at home, I know, but the reason for using that actually dates back to some animal work that we did some years back, also in relation to pregnancy hormones and well-being in MS. That led to us researching prolactin, which is this lactation milk-inducing hormone, and showing that prolactin actually is pro-remyelinating. Domperidone is used for a different purpose, but it happens to generate increased prolactin levels as a result, as a side effect. So we're using that side effect in our trials in secondary progressive and also in relapsing remitting MS. These are very, very small trials. The secondary progressive is is asking whether or not this will fail in that trial. So it's a different trial design. Whereas the relapsing remitting, we're looking actually at MRI signal for evidence of repair. But these are very, very small trials. And in MS, following from these small trials, if promising, we then have to find funding for a phase 2 before going on to a larger phase 3. The disadvantage of using some of these generic medications, and domperidone being one of them, minocycline being another, is that we don't have big pharma, so to speak, behind us to push those trials very rapidly along. We are reliant on foundations and grant agencies such as the MS Society of Canada to fund those types of studies. So invariably they take much longer, but that is a first step, towards trying to look for evidence of its promise.
I'm only going to read a couple more questions. As I said, I have received emails and paper questions I'm going to save for Dr. Walter and Dr. Mary. But can you speak to antiviral use in MS, given the association with Epstein-Barr virus? There's a study using AZT. So those who are treated with antivirals and also many who are treated with antivirals following shingles have real symptom relief. Can you speak to that at all?
Yeah, no, I cannot.
Okay, would that be something that Dr. Mary might be able to, do you think?
Ruth Ann,
Oh,
who has just appeared?
later,
Yeah.
not now.
Yeah, please ask her later.
Okay, I didn't see you there, so I'm holding some questions for you, so be ready.
We are referring all clinical questions to you, Ruth Ann.
Yeah. Stem cell, back to stem cell. Can a stem cell patient enroll in other trials for myelin repair? And if so, which would be the right one? Any comment on that, or should I put that off to later?
Well, all I can say is that I would be very, very surprised. And the reason is that, as I've already told you, the patients recruited into clinical trials, particularly early phase clinical trials, where we are trying to stack the odds in our favor, so to speak, to look for a signal, would sort of, if I were the investigator, dissuade me from using a stem cell transplant individual, because something else profound has happened in those individuals, and I'm a little worried that that might mess up the signal that I would try to get from a new trial that I'm running.
I've just had a question, though, regarding Avonex not being covered in this case. I'm not understanding from the Trillion Foundation or the Ontario Drug Plan. What would be the next option? I mean, that's not really something I think you can answer, nor Dr. Marie, because it is very personal. But my suggestion would be, A, you could speak to our MS navigator that's in the exhibit hall, who can talk to you about maybe what your other financial options might be. But in regards to this particular transference to a new drug, that would be something you'd have to speak specifically to your doctor about. Is that fair answer on that one? I think, I'm just making sure that I'm not missing anything specific to you. Other aggressive antibiotics possibly being considered beyond minocycline. I guess there's a Dr. Weldon in the UK who's spoken about that.
Other aggressive antibiotics, probably not. I mean, the one reason why we went with minocycline is because, well, first of all, the use of antibiotics for a chronic period of time is something that we want to worry about, right? It can sort of breed bacterial species that might be now resistant to other antibiotics, etc. But with minocycline, and recognizing that minocycline has all of these immune regulation properties, and going back now close to 20 years at a time in which we did not have any oral medications and minocycline is given orally, that seemed to be a very good idea at the time, particularly since minocycline has been used actually for fairly long periods in a lot of teenagers who are being given minocycline for treatment of acne, for instance. In the UK, there actually is a database in which something like over 6 million teenagers have been treated with minocycline for at least 6 months. That, plus its use for now over 50 years, led us to the conclusion that the literature around minocycline is that it can be used chronically. It has a low frequency of antibiotic resistance, and that it has a very low frequency of very significant side effects, and that's why we went with minocycline, but we would not be considering more potent antibiotics. And besides, those potent antibiotics may not have the immune regulating effects that we had discovered to be useful for minocycline.
Okay, I think we're going to need to end. I have sorry, there is one question though, sorry. Cool sculpting, is that like when you put that thing around you and, I don't know, cool sculpting, can that help about something? Sorry. Do you recommend cool sculpting or what they are called cold nitrogen treatment?
I do not know about those. So
okay, so it looks like I'm looking at Dr. Mary and I'm looking at, okay, so I won't be able to answer that question. Okay, so the other questions will definitely be suitable for either Dr. Marie or Dr. Walter. And I think I can stop. Oh, something about colloidal silver. Anybody can speak to colloidal silver. Is that how I say it? Colloidal. Anybody speak to that?
Not me, sorry.
Not you? Yes? I'll save that for later, thank you. Okay, so there is quite a few other questions. We're going to start off the next question session really full of some good questions. Dr. Yong, thank you. Thank you.
Thank you.